Good afternoon, everybody, and welcome to the Outbreak Management Advisory Board. Just a hello to those participating in the meeting and equally those watching along at home. You're all very welcome. We've got an action-packed agenda today with an awful lot of items, but I'm sure board members will bear that in mind and we'll make sure that we get through everything properly, but as efficiently as we can do as normal. First thing beyond that introduction and welcome is just to note any apologies for today's meeting. And we received a number of apologies in advance. And actually, Tracy, I'm going to ask if you could verbally whip through the apologies list in a second, just so they can be recorded with the minutes. Tracy.
Okay, so we have apologies from Sian Balsam at Healthwatch York, apologies from Ian Floyd at City of York Council, apologies from Phil Netham, the track and trace lead, and from NHS Vale of York Clinical Commissioning Group, apologies from Mike Padgham at Independent Care Group, apologies from Alison Simmons at York CVS, and apologies from Dr. Sally Tyra at the Local Medical Committee. None of those people have been able to send a substitute. That's it. Thank you, Chair.
That's great. Thank you very much. But I know everybody else that we're expecting is here and present. So that's great. So without further ado, the next agenda item is any declarations of interest that any board members have that they want to additionally declare. So I'll give everybody just a couple of seconds in case they wanted to indicate to me virtually. But I can't see any additional declarations. Thank you all. So that takes us straight on to agenda item 2, the minutes of the meeting that we had on the 10th of February. So in a second, I'll ask board members if they're happy to sign off the minutes. Before that, I'll just check if anybody's got any matters arising, questions or updates that they would like to give. And just to bring to everybody's attention, there are a number of actions listed in the minutes from last time, and those actions have either been done or in the process of being done. And the only one I wanted to flag was action 20 regards the mental health summit. That's been arranged for the 26th of March. Phil is not here today, but he's made sure that Tim Madgwick, who's the independent chair of York's Mental Health Partnership, is going to facilitate that. And I'm sure we'll bring it back as an agenda or perhaps a report afterwards to this board. It was just to mention that to you all. I can't see anybody else wanting to give any updates or have questions. So could I ask for a show of hands, please, to sign off the minutes? Thank you very much. That's a clear majority in favour of doing that. So we'll now move on to the next agenda item, which is an update from Public Health England Behavioural Insights team. And I'm really pleased to be able to welcome a guest to join us today, Dr. Dale Weston, who's the Principal Behavioural Scientist at the Behavioural Science and Insights Unit, who's going to give us a bit of an update on their work and also the work that they're planning to do with the Council through our Public Health team and our Communications team. So Dr. Weston, very welcome, and I'll hand straight over to you.
Thank you very much. Yeah, so what I think I'll use the time to do is I'll give a little bit of an overview of the sorts of things that we do and kind of what we're all about and where we're from, and then I'll talk a little bit about the work that we're doing with York. So just to start, as the Councillor says, I'm from Public Health England. I'm a Principal Behavioural Scientist, and I'm a representative of the Behavioural Science and Insights Unit, and our kind of main remit is to work locally, regionally and nationally to help with the implementation of behavioural science within the COVID-19 response. So we do an awful lot of things like collating together evidence from the literature about what works for influencing behaviour change in what contexts, and we do some more bespoke work like the work I'll talk to you about in a few minutes with local areas like the team in York, where we kind of help to generate and gather insights. Broadly speaking, when we talk about behavioural science, what we're really talking about is how to understand barriers and facilitators to behaviours that we kind of would like people to engage in a variety of different contexts, but I'll talk kind of more specifically about COVID. And what we really mean there is understanding what the behaviours are of interest, understanding why people might be more or less able to engage in those behaviours and the reasons behind that, and then using those reasons, using those insights to come up with some suggestions for interventions that might be effective at trying to help. So it follows very broadly an approach that we would call COMBI, which is it is well cited in the behavioural science literature. I won't go into detail, but it basically means that if you have the capability, the opportunity, and the motivation to engage in behaviour, then you're likely to do so. All of that is to say that there are a load of factors that might influence why somebody wants to engage in a behaviour or not. Those might be whether they know that they have to or whether they know that it's important. It might be whether they're motivated to, but it also might be a whole raft of other things like they can't do a particular behaviour because it would cost too much, or they can't do a particular behaviour because they don't have access, or they can't do a particular thing because they would need to drive to a place and they can't get there. So that there are all kinds of psychological and practical factors that influence decisions to engage in behaviour. And our role is to work and to help with the messaging and the communications to try and increase uptake, but also to try and come up with some interesting and sometimes innovative approaches to trying to make it that little bit easier for people to engage in the behaviours that we all want to engage in. To give you some really kind of general examples, we've been working across the piece, and just to kind of make it a little bit kind of clearer in the more abstract, we do some work around kind of recommendations for improving adherence to guidance in workplaces, for instance. And there we might think, okay, what about car sharing? Some people share cars going to work. There might be issues with car sharing. How can we make car sharing safer? So, promoting car sharing with only bubbles, reminding people to clean their cars, information about improving ventilation is an example. Another example is, okay, if we want people to wear face coverings in a particular context, how do we help to encourage people to wear those? Well, is it an option to make them available to people, as they go into a place, for example? Is it an option to put some signage in really clear locations that's really direct, really specific, and makes it very, very clear what the behaviours we're asking people to do are? Things like that. And I won't kind of labour the point, but that's kind of our role. We are, as a team, generally speaking, psychologists, but we have some epidemiology experts. We've got kind of people from across the range of behavioural science. And with York, we're doing some really quite nice work, which I think is kind of a couple pronged, helping with preparing for the reopening. And I think it's a couple of elements that I'll touch on really quickly. One of them is helping businesses to be COVID ready for the reopening, and that takes a variety of different approaches. One of the things is to gather insights from previous work that we've done and work that we've done around the country on behaviours in businesses and workplaces and retail settings, and to share those with the local team to try and help identify some quick wins of things that we can do easily, but also some other things that we might want to try to see if they're effective. But also we're going to be doing some public outreach and some focus groups with business owners and representatives of businesses to try and understand what they think the challenges are to adopting the various behaviours and to implementing the various behaviours. And that fits very much in we're identifying what the behaviour of interest is. We're trying to identify what the barriers and facilitators are, and then on the basis of those, we'll be able to come up with a whole raft of suggestions for what could be trialed, and then we'll see what fits with the kind of the structures that you have. That work is ongoing over the next, I think, month or so, and then we're also planning some work with residents and visitors, similarly, a little bit further down the line, to understand barriers and facilitators to adherence to the recommendations when they're outdoors or when they're back in the town, when the town has started to reopen again, so that we can understand where the pinch points are, where we might need to focus our attentions in order to try and make it, as I said, that bit easier to adhere. I think that's broadly it. We've been doing some work as well, advising on, I said before, communications, advising on the signage, providing some feedback on the kind of the signage that's likely to go out, which is all looking really great. But that, I think, unless I've forgotten anything, kind of looking at Claire, that I think is a bit of a whistle-stop tour of what we do and what we are doing with York.
Thank you very much for that, which is appreciated. And I was going to ask Claire that I know your agenda item, which obviously includes some of that work, is next. It's
Right.
whether Claire, you wanted us to take your agenda item now and then wrap up questions for Dale and yourself after you've talked about some of the work, if that makes
that's fine.
sense.
Yeah, that's fine.
So if you don't mind staying on, Dale, we'll then come back to you after Claire's presentation. That'd be fantastic.
Mm-hmm.
So we will come back with any questions or comments anybody's got. But if we take agenda item 4, so the communications update, as I know that includes some of the work that we just heard about. Claire.
Yeah, sure. Thank you. Richard, are you okay to share? Oh, there we go. Just like that. Thank you very much. So if we can go on to the next slide, please. So just to remind you all, throughout all of our communications, we continue to reinforce our key messages, which, seeing as we're talking about behaviour, are behavioural led. So wash your hands, wear a face covering, keep your distance, and test. Where we basically hands, face, space, test. Next slide, please. The communications plan is in 3 phases, and this is to match and to marry up with the outbreak management plan, which I know is under review, and I'm sure Sharon and Fiona will talk about that later. But where we are right now, we're in 3 phases of the communications plan. So if we'd like to move on to the next slide, you can see how that maps across the if you like, the life cycle of COVID. I've mapped in the dates for the roadmap to recovery, so you can see where we are now is we're still very much in phase 3, managing the outbreak, for both step 1A, which was when the schools welcomed back children who were not key worker children, and then in the next week, well, 10 days or so, when step 1B starts, and more people can meet outside. And then when we get to step 2 and 3, so the 12th of April and the 17th of May, that's obviously in phase 2, where things are starting to get and feel a lot safer, although restrictions will gradually loosen and more things will open. And then finally, hopefully, we'll get to stage back into phase 1 when we get to the 21st of June, and everything's open in full. If we go on to the next slide, I've got my the communications roadmap, and then after this slide, I've got the actual government official roadmap, because I just want to linger a little bit on the dates. So where we are right now, as you know, you've seen this slide before, this just shows you that the life cycle of the pandemic has been informed by regular communications that go out at the moment in lockdown, weekly or twice a week, the Our City that goes out quarterly, and then the fortnightly Facebook Lives with a number of different campaigns that support that. So emotional health is still ongoing, testing, vaccinations is still ongoing, of course, we'll come on to that, and then the My COVID story. And this month, we've also got the addition of another year on celebration, if that's the right word, where we recognise a whole year since lockdown was called. So we go on to the next slide, please. This one is shamelessly nicked from the government, from the Cabinet Office, and this is just to show you how the steps pan out over the next few months ahead, with our behavioural work very much mapped to these different moments in time. Now, just to remind you, these dates are indicative, so they are based on the fact that nationally, they recognise that we have passed 4 tests, including case data, hospitalisations, etc. But we're working towards these dates being met, because obviously we can move our communications forward, but we can't really bring them back. So if we just go on to the next slide. Sorry, the next one. So this is sharing accurate and up-to-date information, which shows you what we've done over the past month. 16 press releases, continue to share our regular case data, which is picked up by the media, and our daily tweet, which is picked up by our local Jorvik radio. And if we go to the next slide. This just shows you the rhythm of our communications, which have happened throughout the course of the last month. Many of you on this call will have received this. Some of the people watching will have received some of these communications. As you'll see, you might remember last month I talked about a 44% increase in weekly resident e-newsletters. Well, that was partly driven by the floods, of course, and this month it slowed down a little bit to just 9% increase, but still increasing numbers and still seeing that information shared widely on social media. And this month we had our quarterly resident newsletter, which many of you will have received, goes out to all households, and there's the front page of it there, where we talked quite extensively about COVID support and of course the vaccination programme. If you'd like to go to the next slide. So this is our comms approach for the steps ahead. And this just shows you the types of communications that we'll be sharing with you and with the city based on the roadmap to recovery. We've already obviously got through step 1A at the 8th of March, where we supported schools, and I'll come on to the work we've delivered on behalf of the schools and education. And we're right now preparing for step 1B, which is where we're working very closely with the PHE behavioural team, ready to reopen, first of all, parks and outdoor spaces and community areas, and then moving on to non-essential retail as we move through to the 12th of April. And making sure we're ready for that and ready to prompt the behaviours as much as we possibly can before we learn what has worked from businesses, ready for a refresh on the 17th of May. And then we'll learn from residents and from tourists what's worked for them, ready to refresh again for the 21st of June, so that by the time we get to a place where, if you like, the restrictions are at their lowest, and again, we don't actually know what that means, what normality means just yet, we are providing the types of information that will prompt the most safe behaviours we possibly can. So if you can move to the next slide, please. So sharing the roadmap. The roadmap was announced, oh goodness me, I can't even remember when now. Nope, still can't remember when. Anyway, well, the roadmap was announced during the course of the month we've just had, and we quickly made sure as many people could be aware of that as possible, shared it through our business update, our resident update, shared the messaging that we had provided to us from the government, and updated our website. If we can go on to the next slide, please. We've held 2 Facebook Lives to recognise the roadmap initially, and then to talk about returning to schools, which very much played a part of our communications approach to supporting the schools to return. And as always, low views at the time, which increase overnight as more and more people watch it, and it's shared more amongst local communities with more comments added. If we can go on to the next slide, please. So I just wanted to touch on the 23rd of March, it's Tuesday. We are not going to be able to escape it. It is going to be quite a significant event for the country as a whole. In the council, we're very much supporting the St Leonard's Hospice leadership of the event, where they have all sorts of different things going on, including a time capsule. We're lighting the walls in remembrance of the lives lost and of people's lives being so terribly affected throughout the course of the last year, and also recognising the great efforts and the great community response, as well as providing additional support. So we're making sure we provide bereavement support to those people that need it, because it will be a difficult time for many people, as well as a recognition of how far we've come. So if we can just go on to the next slide, and the next one. So where we are right now, remember, we're still in lockdown. So we've been making sure people know what they can and can't do. We've been sharing information around takeaways. So takeaways been a problem for the city in the sense that people have been kind of meeting with friends outside takeout. So we've been helping takeaway premises, move people on, as well as COVID marshals, supporting COVID marshals to do the same. And we've been sharing the national messaging, and you'll have seen the national approach during this lockdown is much more hard hitting and much more about the individuals that have been affected. If we go to the next slide. We've helped schools get ready, so we've built confidence amongst parents that their children are indeed going to a safe place. We held the Facebook Live that I've just talked about. We shared a case study from a teacher in our COVID story campaign, which are always very well engaged with and shared extensively. We wrote to all teachers, we wrote to all parents, which was sent to parents via schools, and extensively on social media, updated the website and provided a pack for schools to share with the pupils and their parents around testing, and particularly symptom-free testing, which we're trying to, as you know, make a regular occurrence for pupils in secondary schools and their households. If you'd like to go to the next step, please. Thank you. So testing, we've prepared for surge testing. I'll just remind you all, we're not actually in a surge testing event. However, with the increasing number of variants that are being identified across the country and the increasing occasions for surge testing to take place, everything from one postcode to, for example, 10 postcodes in Bristol have had to experience surge testing. We wanted to make sure our ward members particularly were ready to catch it should it happen, and that we were ready to run with it as quickly as possible. So I'm sure Fiona or Sharon will be talking about surge testing, but essentially we get a 24-hour window to make sure our local communities know what to expect and how to take part in surge testing. So it's really important we're ready for that. We also continue to promote the testing available, promoted the test and trace contact scheme, which again, we've just issued a press release today about the fact that locally we're taking more responsibility there. Promoted through media, through social media, and also through targeted communications to key groups that were either through businesses, through mobile testing units in different ward areas, or through Facebook admin groups and responding to community Facebook groups. Next slide, please. Vaccination. So this work we've done, we've worked really closely with CCG on vaccinations, initially to share really myth-busting information, what's safe, why it's safe, who can get it, who can't get it, all those sorts of things, when you wait your turn, whose turn it is now. We've shared information through our city, and we're just working with CCG now to actually, as today, in fact, the Nimbus Care celebrated their 100,000th, if I can get the word right, 100,000th jab or patient, and which was a great achievement on the same day that 25 million people have had their jabs across the country. We are now looking at the vaccination hesitancy, which is where people are more reluctant to come forward and take up their appointment and their allocated slot. So we're working with the CCG to understand what's causing barriers and what's causing that hesitation, and whether it's in discrete groups or discrete areas or locations, to see what we can do to really nudge people along so that they line up and get their vaccination as soon as possible. Next slide, please. So we are still continuing with the emotional health campaign, working with partners from the Outbreak Management Board to look at how we can signpost and prompt people to talk more openly about emotional health and the issues that people are struggling with. Information went out in our city. We provided a toolkit to the universities and to higher education to share with their students for Student Mental Health Day at the beginning of March. And we've continued to share through social media, and had obviously 9 Facebook Live sessions that have talked about emotional health, and we'll continue to do so. And we're really excited to hear from and work with the Mental Health Summit so that we can continue that with that frequency, because of course emotional health is of concern to many people. If we can move to the next slide. So Public Health England, this is the work that Dr. Weston has just described, and I've summarised it here so we've got a record of it. Essentially, over the next 3 months, we're running a behaviour instead-led trial. We've already heard from Public Health England about the signage that is already in the city centre, and they've already given us some really helpful advice on how we can improve that for putting in place for the 29th of March, and then again, when more things open on the 12th of April. Following that, we will hold focus groups with businesses, particularly businesses with open spaces, so cafe, those who've got cafe licenses, those those that have maybe queues outside the premises, such as takeouts, those that maybe manage spaces, like, for example, Minster Gardens, or around the Castle Museum, and just really understand from businesses what they've experienced and what their expertise is telling them, and how people are behaving in their particular areas, so we get a better understanding of what we can do to support people. We're taking very much a citywide approach. So the first thing that's happening is on the 25th of March this month. We're very excited. We've invited Public Health England to share the available insight with business owners, so that they understand how they can get their spaces as ready as possible in advance of reopening. And then after that, we'll run the focus groups, so that we can basically refresh signage and work with businesses to continually to improve, ready to get to the point where after May the 17th, we'll invite residents and visitors to tell us their experiences, and then after the 21st of June, hopefully we'll be in as best place as we can be, and then we'll poll businesses and ask them what they think of the changes. So if we can just go to the final slide, I think there we go, a little summary of everything that's going on. And there we have it. So thank you very much. Happy to take questions.
Thank you, Claire. At the start, a couple of the slides were not popping up as quick for me as I imagine intended, but whether that was just my screen. But I'm sure you'll attach the slides to the minutes so that they go up on the council website afterwards. So as you say, it's there as a record. But as promised, I will now open it for any questions or comments for Dale and Claire about the comms work or that trial in particular. Sharon.
Yes, thank you. I think this is a really exciting piece of work, and I'd like to thank PHE for supporting us with this. We know, don't we, that York is a fabulous city, and we know that people will want to come and visit. We saw what happened in December when lots of people came to York, and we had a rise in case rates, infection rates correspondingly, despite all of the hard work that we did to try and keep the city safe. So we know that people will want to come to York again. And so this citywide approach with Claire's team and with Public Health and Public Health England, I think is a real opportunity for us to again do what we do so well in York, and that's really about coming together as a city in working with our businesses to give that confidence to residents and visitors, but also the people working in our shops and hospitality, etc., and that York is as safe as we can possibly make it. So I'm really pleased to see this work happening, and I'm really looking forward to seeing the results of it. So a good job.
Thank you very much for that. Probably a couple of questions for me, but might be for different people. The first one, Claire, you mentioned about the vaccine and take up, and obviously potential issues amongst either different groups geographically or by other sort of categories. I don't know whether Dale or Steph, you had any insight on that, and in particular whether there's anything more we as a board or our organisations should be doing to reach out to any of those groups that we feel are not getting the messages through about that. It's first question. And then second one was around the project and business involvement. I don't know whether James and the LEP were looped in, because then that could be shared in York, yes, but across York and North Yorkshire in terms of what comes out of the work. Dale, if I go to you first, and then it's Steph, if you had anything to add, I'll bring you in, Dale.
Yeah, no worries. So in terms of engaging different communities, I don't have up-to-date data on kind of which communities or which groups are uptaking the vaccine more or less. But in terms of reaching groups that we know or think might be kind of a little bit less heard, or a little bit more kind of experience a little bit more vaccine hesitancy. A lot of it is around choosing messengers and choosing ways of engagement that work for those groups. So it's about using kind of champions or leaders within specific communities to target them with the messaging, making sure the messaging is transmitted through the relevant routes and the relevant sources, and making sure that it's clear. I mean, all the usual stuff goes along with that, making sure it's clear, making sure the behaviours are concise, making sure that the information around safety and effectiveness are well kind of communicated, and making sure also that that it's easy to do. So some of that insight gathering stuff that I talked about is stuff that that one can do in local communities through community champions, or if there are other kind of local groups that work within those communities. You know, if just asking the question of people, and you might hear, so for instance, there might be a group or an area or a community that's struggling because can't get to a vaccine clinic easily. For instance, it could be as simple as that. Or it could be, we're not getting the information through because we don't go on gov.uk's website. It could be that straightforward. So it's about using the already existing, and I know in Yorkshire and Humber, already really good kind of community level groups and community level teams to communicate.
Thank you very much for that. Steph, I don't want to take your thunder from your later agenda item, but anything to add?
So in the later agenda item, I'll talk about the big numbers that we are achieving through the vaccination programme, but that also means that we're starting to do the detail on drilling down into those seldom heard groups and understanding how we need to flex our approach to support the groups that we are identifying maybe aren't coming forward. I mean, I have to say that for York, the numbers by comparison are small, but that just means that we can then focus our efforts. But if I can give the board some assurance, we've started to do that work with our Public Health England colleagues around both community data, but also ward-based data. And we've made a number of overtures to community leaders, and we're about to do some direct communications as we approach Ramadan, for example. So opening up the opportunity for people participating in Ramadan to have their second dose sooner, because the 12-week period will hit in Ramadan. So those participating in Ramadan may not take their vaccine during the day when the services, and then in after dusk, it's a time for family. So that's just an example, but we are about to drill down and start doing more of that work, and just reflecting what Dale's commented upon. It's our responsibility to go to those communities to offer and make the vaccine offer to them, and create an environment where it is easy for them to take it up. So we will be looking at a whole variety of things, including how we do pop-up sessions that are away from the centralised model in York, and also we'll have more pharmacies coming on stream in different geographical areas. So it's certainly front and centre on our agenda.
Thank you very much. Fiona.
I just wanted to say, yeah, I'm going to present the first lot of some of that data around ward level vaccine update a little bit later. So that'll be a bit of a start. Obviously, you know, where you live is not the only factor. There'll be other things that we'll learn as we go through this process that Stephanie has kind of alluded to. But yeah, so we'll start to get, and hopefully that data will, you know, get richer as we go through, and we'll be able to bring that to the board.
Thank you very much for that. So we're being asked in the papers today primarily to note that project with PHE is going to happen, and equally note Claire's update. And obviously, as said, I'll make sure that's attached to the minutes and is shared. And I'm sure all of us will look forward to some feedback, insight, and changes as that roadmap develops over the weeks and months to come. But thank you, Dale, for joining us. You're more than welcome to stay, but equally, I'm sure you've got lots of things to be doing.
Yeah, I think I'll drop off, but it was great to see you all, and I'm sure I'll be back to talk about it again later.
Great. Thank you very
Thanks.
much. And thank you, Claire, for your presentation as well. So that takes us through onto agenda item 5, which is the current situation in York, and I'll go straight over to Fiona.
Thank you. So you've all got the kind of one-sider in the papers, which gives you an update in terms of where we are in terms of case rates and various other factors. What I wanted to just do is to focus in a little more detail on a few things within the data that we've got. So I'm just sharing my screen, and hopefully these slides will keep up with what I'm saying. So just in terms of, obviously you've got the epidemiology in terms of the epidemic curve in the pack. This is a bit of just to focus in on what's happened more recently. So this is running from the 4th of January, which was kind of when we went into lockdown and where our case rates were the highest. And so this is what we've seen on a daily basis in terms of the number of cases each day in York. So as you can see, in the more recent days up until the 11th of March, we're around about 9 or 10 new cases every day in York. And a large proportion of this in the more recent data does relate to what we've seen and what we've found in terms of our school testing program. So on this graph here, you can see that this is the number of cases in each of the age bands. So you can see sticking out there, the 10 to 19 age group is where we have seen the highest number of cases between the 1st and the 12th of March. And that's obviously impacted in terms of what we've seen in terms of our 7-day rates. So for those people who kind of follow our daily tweets out, our 7-day rate has kind of, it's come down to just below 50. It's now slightly up above 50. So we're kind of hovering around that 50 cases per week per 100,000 population. So just to give a bit of an overview around that school testing then and what we've seen happen there. So as people will know, there was a request that children of secondary age who were returning to school on the 8th of March should be tested for COVID using the lateral flow tests, which are the rapid tests, as they returned to school. Through discussion with the heads across the secondary schools in York, we agreed that we would start doing that testing on the 1st of March. The schools were keen to get back to testing get back to teaching on the 8th of March when students returned, and also from a public health point of view, if there were people who are asymptomatic in the school community, we really wanted to find them before they got back on a school bus or back into the school environment. So we did that, and we used a kind of mixed model whereby some schools offered testing within the school site from the 1st of March, and others directed their parents and children to come to one of our community testing sites. So in that first week, the 1st to the 7th of March, we found 27 positive cases across all of that testing, whether it was in our community site or whether it was in one of the school sites. So that basically meant there were 27 children identified at that point who were positive. Obviously, those children and families had to isolate. But what it meant is that there wasn't 27 school bubbles, which could be a whole class, a whole year group, who were then having to isolate and be sent home, having just got back into school. That testing continued when children returned to school on the 8th of March. So the idea is that children would have had 3 supervised tests. So we continued doing that testing, and a further 14 positive cases were found in that second week. So obviously that did impact on some of those schools where the children had contacts within the school setting, who then would have had to isolate as contacts of a case. But certainly a much better picture than if we had have done all of the testing from the 8th of March when all the children were in school. I just wanted to show where we are in terms of hospital admissions at the moment. Claire mentioned the 4 tests that we have to meet for each stage of coming out of lockdown, one of them being what the pressure on the NHS is like. So we can see from this graph that obviously from the peak of people being in hospital at the beginning of January, those numbers both have been coming down since that time. So you've got both the number of COVID patients in general and acute beds, and also along the bottom those who are in ITU, and they are coming back down to much more manageable levels at the moment. One of the other measures that nationally they'll be looking at is in terms of COVID-related deaths and what they are looking like. So the green line along the bottom is our COVID deaths for York residents, and then the red line at the top is all deaths and how that compares to what you would expect to see within the population. So you can see from week 1 of this year, we obviously had an increase in COVID cases, and that took our all-cause deaths over what we would normally expect to see at this time of year. That is coming back down to sort of more in line with what you'd expect to see, which is obviously positive. Oops. The other thing I just wanted to show was some of the data that we get from NHS 111 triages. So these are basically people who ring NHS 111 with a health issue, and having discussed that with the person on NHS 111, it's deemed that actually yes, it could be COVID, and they're advised to go for a test. So the black line there is our COVID cases, and you can see that the red line, so those people ringing with symptoms of COVID, maps quite closely. So this is something that we want to look at more going forward, because it gives us quite a good indication of when we start to see symptoms in the population going up, which might then indicate that we're going to get an increase in cases. So we will continue to carefully monitor this, and it gives a good indication as well about illness in our population. Obviously, with the rollout of the vaccine, what we hope is that even though there may still be transmission in people who have been vaccinated, that they will be less ill, so less likely to be seeking NHS support for their symptoms. So we'll keep that under close monitoring. So I wanted to come on then to talk a little bit about vaccination. I know Steph will talk about sort of overall numbers of people vaccinated, etc. But this is just some early data that we're looking at in terms of vaccination rates by our wards. It's quite interesting, just particularly on the back of the item we were just talking about. So we can see Bishopthorpe here has the highest uptake of the vaccine so far. So a couple of things, that seem fairly obvious about that. It's a reasonably affluent ward, and it's right on the doorstep of our regional vaccination site, so it's really easy for people to get there from Bishopthorpe, and we've potentially got a more motivated population there. So that's a really good demonstration of those things that Dale was just talking about. But then when we compare that to some of our other wards that are less affluent, perhaps, we can see the vaccination uptake is much lower. And just to kind of compare that, so this is our wards by what we call the deprivation score. So on the bottom axis over on the right is our more deprived wards. And so what you can see is that in the more deprived wards, the uptake is likely to be lower of the vaccine, and in the least deprived wards over on the left, the vaccine uptake is much higher. So as I said before, area where somebody lives and deprivation is one factor. Obviously there are multiple other factors that would influence people's uptake, so that'll be something that we hope to get more detailed information on as we go through, but I hope that's helpful as a first start on that. Thank you.
Thank you very much, Fiona, and open it for questions or comments. I think the thing that jumps out, Fiona, and will welcome more work once you begin to analyse the data and what work that we can do. Was obviously, I think, Guildhall ward, the city centre was significantly lower, including other sorts of comparable areas. So whether that is one of the areas that your team would have a first look at.
Yeah, so I think, now that we've got this data coming through, and it's definitely something, building on what we were talking about how do you utilise champions in that ward area, trusted people to get those messages out. So certainly now that we're starting to get that picture, it really does direct where we need to start putting our efforts in the areas to start working with first.
Thank you. Charlie.
Thank you, Keith. Thank you, Fiona. I was interested in that graph with the NHS 111 calls and the case rates. In the first part, the case rates lagged the calls, but in the second peak on that graph, they aligned. What's the explanation for that difference, if there is one?
Well, I was wondering about that myself, and I think there's probably a couple of things. I think one thing is at the start of the pandemic, there wasn't access to testing in the same way as there is now. So although the case rates looked perhaps a bit lower, it was probably just because we weren't diagnosing people. You only really got a test if you were in hospital right at the start. And then I think I wondered as well whether some of it was that if you kind of remember back to probably April, May time last year, there was a lot of anxiety around COVID, and so I do wonder whether there was more of people with symptoms, that might have just been, a bit of a cold, whatever, who were more likely to ring NHS 111. I think there was a feeling of as soon as you got a cough, this could be COVID, and there was quite a lot of fear around it at that time. So people probably did make contact with the NHS perhaps more than they do now. But that's just a feeling. I don't have the evidence for that.
Thank you very much. I can't see any further questions at this stage, so we're being asked to note Fiona's report. Before I do, I was just going to check, Amanda, if you wanted to add anything on school reopening in particular.
Thanks, Keith. No, just to say that it's gone really well. Say huge thanks to the public health team for all that they've done in conjunction with schools, and obviously a massive thanks to all of the schools, all of the parents, all of the children for making it go as well as it has done. We've had really high attendance levels, over 90% attendance in school today, and just some lovely stories of, you know, children being really excited about being back at school, being back in the classroom, enjoying being back in learning. So it's been great.
Thank you very much, Mark.
Yeah, I just wanted to add to this. We've bus operators had COVID wardens at some of the schools to help with transport and sticking to the social distancing rules and all the safety measures that come around it. And we've had a really nice note from the head teacher of Joseph Rowntree School saying that that has worked extremely well, and certainly the feedback from my staff is that that the general compliance with all those measures has been excellent and continues to be. So it's been a great story actually, and certainly my thanks as well goes to the schools for really playing their part there.
Thank you very much for that, Mark. So on this one, we're noting the current situation report, so we can do that and then move on to agenda item 6, which is the update on the vaccination programme that I might have started a little bit earlier. Steph.
Thank you, Keith. So you've got the general impression that the vaccination programme's going very well in York, and given that we're sort of mid-March, we often don't reflect on this, but I just wanted to take a moment to just talk about Askenbar specifically. So that runs a regional service that's open to the national booking service, and it runs our local vaccination service. That's supplemented by our hospital hubs, so at York District Hospital and our mental health provider, TZ and Weir Valley. And we also have pharmacies. But it's just to say, when we talk about the vaccination programme, Askenbar in particular, it's on the Park and Ride site. It has volunteers running the service and marshalling it from the voluntary sector. It has fire and rescue there. It accepts all donations and lovely treats from local businesses, and it's staffed by a range of health staff, from students, from healthcare assistants, from GPs, active and returners who have retired. So but it's been a real collective effort. And of the total population of York, we are reporting as at the 15th of March that almost 37% of the total population have been vaccinated with a first dose. What that figure sort of boils down to a bit more is that those that are eligible for a vaccine, so people over the age of 16, actually we're at 65% who've received a first dose. And those in the early cohorts, so over age of 60, there are anywhere over 90%, and our care homes are at 95, 97%. So when we reflect on the death rates and the reflection that we will all partake in at year one, the vaccination programme is having a really significant impact. I know we've got a very tired workforce, but they're still really focused and really energised by the vaccination programme. So I just wanted to highlight that, because there's a huge human element of coming together and working in collaboration. So that said, those big numbers are starting to highlight and make us think in a different way about making sure that everybody feels that they have equal access when it becomes available, and the National Booking Service is now open to over 50s. As always, supply dictates the availability, and we are now starting to work through the logistics of people coming and being called at 12 weeks for their second dose, and we're also making sure that those who had Pfizer as a first dose have Pfizer as a second dose. We're also planning the logistics of those who had AstraZeneca as a first dose, have AstraZeneca as a second dose. So we're starting to see some of the logistics on site. But that said, if people are linked into Nimbus Care, which is the collaboration of the city GP practices, will know that Askenbard did, I'm going to stumble over saying the 100,000th jab. They did that today, so a really great achievement. So we are starting to see younger ages coming forward now. I'm smiling because over 50s is a younger age bracket. But we are for the first time seeing that working age group probably not being available to come forward for appointments. So they've got greater demands on their time potentially. And so it's not that we're seeing people not turn up, but what we are finding is gaps in our appointment schedules as people are having to move around and not taking the first appointment offered. So that's something that we're seeing for the first time. But our mantra is no waste. And so we, all of our practices and our services run sort of short availability lists. So yeah, I think it's a pretty well-oiled machine now, is the vaccination service actually. And post Easter, we, as I say, we'll start to look at a decentralized model using the pharmacies, as we have already done, setting up pop-up sites so that we can provide more accessible services. Yeah, we will also see, I think, after Easter, if the current pilot sites roll out that way, the Moderna vaccine being introduced as well. So when we think about availability and spread of available vaccines, we're well placed to move into what we call cohorts 10 and 12, which is all those age brackets below 50, so the 18 to 16 year old. So a really positive report. And if we link together the other previous speakers, the reduced impact on both inpatient admissions, but also the acuity of those admissions, we can really see the impact on our more vulnerable residents of the vaccination programme.
Thank you very much. Sharon.
Yes, thank you for that update, Steph. Very, very helpful. I just have a question about vaccine supply. Just beginning to be contacted by residents who have perhaps read something in the media about concerns around vaccine supply slowing down. Do you have any updated information around that?
So I think there's two things going on. We have a phrase which is we all cross the finish line at the same time. So you perhaps heard me talk about there is a movement of vaccines across the Humber Coast and Vale to make sure that the availability is even, so that priority cohorts get availability. And that's been the position over the last few weeks. But we did get official notification today. So we'll have informed residents in advance of me. We just got notification today of a slowing down of some of the availability of vaccines over the next 2 to 3 weeks. And again, if people recall, it was a similar situation, I'm going to say back in mid-February. The evenness of the supply of vaccines is just something that we respond to occasionally, but we are anticipating a reduction in the supply of vaccine over the next 2 to 3 weeks.
Thank you. Julia.
Thanks. I was just wondering, obviously there's been a lot of hoo-ha around blood clots and all of the rest of it, which hopefully from an official point of view has been dealt with now. But I'm wondering whether we're seeing any increased concerns around some of the vaccines as a consequence of some of this reporting.
So in our vaccination centres, we have not actually, and I tested that yesterday and last week. So you're right to say that there's been numerous official statements that the concerns around blood clots are not borne out by the evidence. Elsewhere in our Humber Coast and Vale region, so towards the East Coast, they have seen the impact of vaccine hesitancy much more. So again, that linked theme about making sure that we understand why people aren't coming forward, and then we flex our approach. We will keep a watching brief on that, because what we do know is that the right person engaging in a bit more time to have a conversation with somebody to allay their fears, and just giving them that time to have a conversation about what's making them hesitant. That's the way that we see greater improvement. But specifically around the reports of blood clots, no, we haven't to date seen a reluctance in vaccine take-up.
Thank you very much for that update, Steph, and the questions which we're noting. And then that can take us on to agenda item 7, which is an update on the lateral flow testing strategy in the city. And back to Fiona.
Thank you. So there's a paper in the pack that kind of sets out what we're asking of the board. Basically, in terms of lateral flow testing, it's a very quick moving agenda, really. So coming back again to the board with what our next phase might be and seeking members' thoughts on this. So in the paper that you have, we've kind of set out at the moment what the key ways of accessing lateral flow tests are. So basically within York, there are various workplace programs that people can access if their workplace offers that. We have our 3 community testing sites, which at the moment, the eligibility for that is basically anybody who has to leave home to go to work, or anyone who is providing care to somebody who is vulnerable. And we also, there have been various other programs, so notably testing of university students, more recently the testing of secondary school pupils, and then the most recent development has been around what is called Community Collect, which at the moment is a way that what they call school bubbles can get access to testing. So that's basically anybody who has a child at primary or secondary school can access testing for the rest of the family, and that in York can be tests that can be picked up from either the Poppleton Bar or the Wentworth Way sites in the afternoons, and for people who really can't get to one of those sites, you can order them for home delivery. So everything that we're picking up in our conversations with the regional and national teams is that there is a clear ambition to make access to testing easier for a wider group of people. So some of the other things that we're hearing that are likely to be coming online sort of end of March, beginning of April, one of the things is Pharmacy Collect, which similar to the kind of Community Collect model, whereby lateral flow tests can be picked up from a local pharmacy. We're yet to hear more detail about that. And also in terms of the Community Collect, the feeling is that whilst that at the moment the eligibility is for those school-based families, that the criteria for that service will be broadened out, and that very much these programs are seen as a tool to support us as we come out of lockdown, and that testing just becomes something that we all do as we get back to some sense of normal life. So we're obviously thinking about what our offer will be to residents going forward, and how we adapt what we currently have. So within the paper that you have, there's 3 options. Option 1 is basically that we carry on as we are with our 3 testing sites in York, and we let those government initiatives kind of roll out around us and let them get on with delivering those. Our feeling with that is that obviously as there's more access through the collect model, footfall at those 3 sites is likely to get less, as people will either access the Community Collect. We've got more workplaces setting up their own testing offers as well, so we would likely see that reduced demand for testing in our sites. And one of the other issues is around test quality. So, you know, we are slightly concerned that the more people who can just, you know, pick up tests and do that testing at home, whether we start to see the quality of that testing drop. And also within that option, you know, it's not really a tailored approach to what we know about our population. So then we've got option 2 in the paper, which is the kind of other end of that scale, that we kind of move over to completely a home testing collect model. So we would look to have more venues or locations whereby people could come and pick up those test kits, and we go down that route of that kind of access for people. The options, the issues with that, I think that there will be an element of our population who would quite like somebody else to do the testing for us. We've got some quite sort of nice stories of people who go to our existing sites, you know, for example, people who are partially sighted, who want someone else to do that for them, people with learning disabilities who want that support around doing the test. So that option wouldn't, you know, provide that offer. We also, we don't know some of what's yet to come. So as an example, we're still waiting for guidance around what the expectations are when more students go back to face-to-face learning. So if there is an expectation that they would need some kind of supervised testing before returning to learning, we wouldn't want to have completely done away with all of our testing facilities if there's an expectation for that. And again, there's that issue with testing quality if we move towards everybody just doing home testing. So our option 3 is what is our preferred model, which is basically a dual approach whereby we keep our test centres who can offer tests for those who want it, but probably with a reduced number of testing bays, and they also function as a site where people could come and collect tests for those who want to go down that home testing route, but also that within those test centres there is an opportunity to do either, you know, a demonstration of testing for people, ability to have staff who can answer those questions that people might have to kind of you know, drive up that quality. So it's not just a here you go, here's your test kit, get on with it kind of thing, that there's a bit of support and guidance for people around that. So as I say, that's our preferred option that we would suggest going with. We think it, you know, it gives that offer for people who want someone else to do the testing. It tries to address that issue around quality. It also means that we can, you know, if we are expected to do any sort of wider scale testing of particular groups, we've still got our trained staff who would be there and able to do that. I think one of the things certainly that we've discussed, obviously we don't know what will happen in terms of pharmacies, whether we'll have pharmacies taking part in this from April or later, but certainly at the moment we've identified that we have a bit of a gap in the kind of southwest of the city, so we certainly would, with this model, want to look at potentially other venues or parts of the city that don't have good coverage in terms of access to that kind of testing. So be grateful for any thoughts on that from board members.
Thank you, Fiona, for that. Any questions or thoughts from anybody? Mark.
Yeah, I think I was going to try and sneak this in as an AOB anyway, so it's good that it's coming up now, to be fair. The testing in the workplace, which probably links to that as well, is we've got some experience from around the country, and it is, well, very challenging to set up, especially in some businesses. So the kind of dual approach I would certainly favor, because it would still give people the opportunity, especially in bigger businesses, to collect this stuff. But also you can still refer those that are a little bit less inclined to do so to the testing centers. I guess the question that I wanted to bring with that is, could it be explored that actually workplaces are being issued with test kits to take home, so that you know, people only have to go one way, and it encourages them to, when they're at work anyway, to collect kits rather than having to go somewhere else to collect them. So that was just something I wanted to see if that could be considered.
Fiona, did you want to come back on that, and then I'll go
to it's a tricky one. Partly I don't know, because we're still waiting for the guidance around what the collect model will be and what the requirements are around that. But potentially, yes, I think that could be an option. So I think if there were an employee, you know, had a reasonable number of employees who wanted, you know, I think that we could probably set you up as a collect site and enable that to happen. As I say, we're still kind of waiting for some of the detailed guidance to come down around this, but I think that would be something we could have a conversation about.
Thank you for that. Sharon.
Yes, I just wanted to add really the requirement that Claire touched on in her presentation earlier about the need to do surge testing. So as part of the government's roadmap, the local area COVID outbreak identification and response, as they call it, is very much reliant on local authorities being able to respond very quickly. So if a new variant of concern is identified in a particular area, we only have 24 hours to be able to respond, to do intensive testing in areas that are not determined locally. The areas that we need to do surge testing in is decided by government on advice from the Joint Biosecurity Centre and Public Health England. So option 3 really gives us that flexibility. It means that we're maintaining a core resource to be able to offer testing. We're supporting people around collect for those people who want to and feel confident about testing themselves at home. But we can rapidly scale up that support then if we needed to do surge testing. Whereas the other options wouldn't necessarily give us the flexibility to deliver both of those approaches. So it would be quite risky, I think, for us to go for any other option but option 3.
Thank you very much for that. So I think following Mark's comments, and I could certainly see lots of nods on the screen when Sharon was suggesting the option that is in Fiona's paper. So unless somebody waves at the screen or indicates now, I would take that we were happy with that recommendation and that direction of travel. Fiona, did you need anything else? Again, I can see lots of nods from board members from that item.
No, that's really helpful, thank you. And then we'll be able to update with how we get on. And as I say, it's a very fast changing landscape, this, so I'm sure there'll be more changes as we go ahead in terms of what's rolled out nationally.
Thank you. Charlie.
Thanks, Keith. I'm very supportive of option 3. We will face a challenge of students wanting to do sport and the facilities in which the 2 university centres are currently based. I know we're thinking hard about that together with colleagues from the council and may be able to find alternative accommodation, especially if the demand levels are going to be lower with other sources of tests. So I just wanted to enter that proviso. We'll make something work, but it may not be exactly what we have now.
Thank you very much for that. I think obviously gives us a further reason to adopt the approach that Fiona and Sharon are advocating. Thank you all for that. So that then takes us on to agenda item 8, which is a verbal update at this stage of the refresh of the outbreak control plan that I know will come back in April for final sign-off. Sharon.
Yes, thank you. I want to start off by saying a little bit about the feedback from our peer challenge, the LGA peer challenge that we had last week. I think probably a number of members of the board were present at the informal feedback session that we had. The timescale for the formal feedback is that I hope to receive the final written feedback by the end of this month. Obviously, we're dependent on the LGA's timescale with that, but I would hope that we will get that written feedback by the end of this month, and then that can be presented as a report to the next meeting of the board on the 7th of April. Clearly, the peer challenge was good timing for us in terms of refreshing our outbreak management plan. We developed it last summer, and it was signed off in July last year. And obviously, a lot of time has gone by since then. We understand a lot more about coronavirus. We've understand a lot more about what has worked for us as a city, what's gone very well, and also some of the really good lessons we've learned, really building on good practice that will stand us in good stead as we go forward. I think the difference between this refresh plan and the current plan is that we're moving into a new phase of the pandemic. The pandemic is still with us. We still need to ensure that we have a really effective outbreak identification and response. But we're increasingly moving into a phase where we hope not to need any more lockdowns, and that we're moving into a phase of learning to live with COVID. So learning to adapt our behaviours and our lifestyles to be able to live safely with COVID. And also planning our city response to that. So we've talked a little bit about businesses, but also touching on the NHS. There is a significant restoration programme that the NHS is going to be working on to recover from a lot of the activity that has had to be put on hold. We're also expecting increased demand on a number of our services, particularly health and adult social care. But picking up some of the discussion earlier with Dale and with Claire, very much central to learning to live with COVID is going to be about how we can adapt as a city across all sectors, and also how we can work with residents and visitors to the city, so that we can keep the infection rates low. We know that the success of the vaccination programme, the ability to keep infection rates low and to protect the NHS are going to be key going forward, so that we can continue to lift restrictions and not have to go back into lockdown. But we also know that the pandemic is going to be with us for some time. As we move into summer and then into winter again, we may see a resurgence of infection rates, and so we can't relax our outbreak response. That continues to be very important. And so the refresh of our plan will continue to focus on everything that we need to do around prevention and outbreak response, but it will focus much more on recovery, which wasn't really a strong feature in our current plan. So the timescales we have to work to for this are extremely challenging. We have to submit our refresh plan this week. So what I'm proposing to the board is that obviously we have no choice but to meet the national deadline to submit our plan, which doesn't give enough time for consultation, but that we submit that as draft. a draft plan then comes to the next meeting of the board, and that we then do some consultation on that plan, with a view to officially signing it off at the 19th of May meeting is what I'm proposing. So I'll would welcome comments from the board chair on whether that proposal is acceptable.
Thank you very much, Sharon. Any questions or comments? If not, we'll note that as acceptable, and obviously look forward to the April board meeting, where we'll both get those updates, as you say, about the new outbreak control plan, but also the feedback from the peer review as an agenda item, so that we can discuss that then. I can't see any indications to add to that. So that then takes us on to agenda item 9, update from the Universities and Higher Education Group, and over to Charlie.
Thank you very much, Keith. The recent meetings of the subgroup have focused on 2 critical points. The first of those has now passed, and that was the return of college students from the 8th of March, supported in that return by on-site testing. There were quite a number of concerns in the run-up to that date about the supply of tests and getting everything in place in time, but it just about worked out. And I think the return has gone well. There have been very few positives, and I think the situation has moved past that critical point, which I'm very pleased with. The second critical point is a bit further ahead, and that's the start of the university summer term on the 19th of April. There will be a substantial return to in-person teaching at that point. We don't know quite how much yet. It depends on what the government says over the Easter break. But for the University of York, it will involve between 35 and 40% of all students. That's one issue. It will bring lots more life onto our campuses. We've not had any significant evidence of classroom-based transmission, but more people will be there and more people will be milling around. At the same time as the other relaxations over Easter will take their effect. That's the rule of 6 outdoors, the return of outdoor organised sport, the return of gym activity, and of course outdoor hospitality. And that all of that together is going to transform campuses from quite quiet places to really quite busy places. And that's a risk point we need to focus on and think hard about managing through a review of all of our health and safety assessments, a very comprehensive review of messaging as the city itself is doing, as we heard earlier, and a big focus on maximising take-up of on-site lateral flow testing. In addition, we'll be putting on lots of activity outdoors, lots of structured activity outdoors, including some teaching, but also all sorts of opportunities for students to meet in their clubs and societies, in their groups of fellow course mates, and so on. We're putting up at the University of York another 4 covered outdoor spaces, which will be of semi-permanent, sort of 15 to 20 year type construction, in order to facilitate all of that. In addition to that, the report picks up 2 other points. One, a note on the peer review. We'll hear about that more next time, but we've had the briefing from the peer review panelists, which felt that the work we had been doing was valuable in its collaborative spirit, but also the value we've got from that in sharing information, expertise, ideas, and so Final thing to note is we're very pleased that the rapid results testing sites at the University of York and at York St John, alongside the one at the community stadium, have supported the return of students to school by offering an initial wave of mass testing prior to testing in schools, and now following that testing at home. We're very pleased that went well. It seemed like we had a good part of Fulford School certainly going through the university's site as well as others. That's all, I think, Keith, for today.
Thank you very much for that, Charlie. Julia.
Hi, Charlie. As the mum of a teenager who's been stuck at home when she should have been at university, it's really interesting seeing the impact it's had on students, and I think they're one of the groups of people who've been most impacted that there's been least discussion about. The impact of just sort of being in your room for 6 hours a day, studying books online and having virtually no social interaction because all your friends are scattered around the country, I think has had quite a profound effect on students. And also quite a lot of them who were in the first year when all of this happened haven't had the chance to make the friendships and build the relationships that you would normally have in those sort of early days at university. And so I suppose I was just wondering what universities are planning to do around the sort of social side of things, bearing in mind that it's still going to be difficult, and to try and give, you know, young people some semblance of a university experience.
Crucially important. And I'd say to an extent, students have voted with their feet. We peaked in our on-campus presence of students at around about 55% attendance, which is way more than are eligible for in-person teaching. I think they've interpreted the guidelines around well-being. If it's better for your well-being to attend, even if it is for online education primarily, then you can, and frankly many have, because they can at least spend time with their flatmates. The really instructive thing that we've seen from the surveys of our students that we've done is that the thing they most want is to spend more time physically with their course mates who are not typically their flatmates. And that's the thing that we're going to be thinking very, very hard about. Now, some of that will come from the resumption of in-person teaching, the rule of 6 and so on. But we want, in particular, using the outdoor covered spaces that we're going to set up, to have them bookable by students in course groups. They'll be outdoors, there'll be distance seating, it'll be pretty much as safe as it can be. And alongside the opportunities for student societies to resume some of their activity, alongside the opportunity to do sport, I think we'll have some of that wider student experience back. We'll have outdoor hospitality. We have a very safe space on campus, again, outdoors, covered. Students were going to that. It was fully booked out through towards the end of November when we were allowed to have it, even when it was absolutely freezing. And we're really looking forward to the opportunities that will bring when the weather is going to be kinder. So we think very, very hard about managing that carefully, but we do want to give our students some of those other interactions that are absolutely part of what they go to university for.
Thank you very much for that. So we're noting that update, and that will move us on then to agenda item 10, which is items for the next agenda. So as mentioned earlier, we've got the revised outbreak control plan coming back to us, and also hopefully feedback when it's received from our peer review. We also had earlier quite a discussion when we were looking at vaccine progress and the new data. and the effect across different wards. And I know, Mark, you had a suggestion for an item whether you wanted to come in now.
Yeah, I think it would be great to see if we can get a report back really on any potential actions we could take to drive up that vaccine take up across the wards, seeing as we've got really solid data that shows us where we might need to focus on. And I say this both as a member of the board, but also in a capacity as providing transport across the city, because if there's something that needs to be done with connectivity, then we can step in and work with the council and the various parties to make that happen. So it'd just be good to see, basically a report back with some pointers on what we might need to do to improve that.
Thank you very much. It almost seems like some of the previous areas where we've had working groups, given the work that's going on with behavioural insights, whether that's something to look at. But Sharon or Fiona, any ideas on that? Sharon.
So there is already a vaccine inequalities group that I think we could ask to look at this. So there is public health input into that group. We will be sharing the data that Fiona shared with us today. It's got CCG representation, GP practice representation, as well as public health. So I think we can ask that group to take that forward and perhaps do a report next time on what the recommendations that group feels need to be taken forward.
Thank you very much. That's great. And I think, like Mark just reflected, I'm sure there'll be organisations on the board, but then particularly in the community voluntary sector and communities that would then be really happy to get involved with that as well. So that would be great if we could add that, and I'm sure we'll come back to it again. I'm seeing lots of nods, so thank you for that. And just to check, are there any other agenda items that people would like to suggest? Equally, please do feel free to contact us as normal between meetings, and we'll pick that up for the next agenda. So if not, agenda item 10, dates of future meetings. So our next meeting is on the 7th of April and then the 19th of May. So just to remind everybody of those meetings. Equally, we don't have a slot on the agenda for partners to give updates. So again, just to make the offer that if anybody on the call did want to tell us about something in particular their organisation was doing, please just flag it as an agenda item or before the meeting, and I'll obviously make sure that there's time for that. And then the final agenda item is any other business. I've not been told of any, but that does not mean that there is not. So just to give a couple of seconds in case anybody wanted to raise any other business. If not, just to thank everybody who is watching at home, to thank all board members and those that participated today. And as just said, we'll be back together on the 7th of April. So thanks all, and bye-bye.
Confirm that the live stream's now ended.